with us is Professor Mohammad Rela. I don't know how to introduce him. He's one of the most leading liver transplant surgeons in the world and is a living legend. He has the world record of transplanting the youngest patient in the world. So I won't take much of the time introducing Professor Mohammad Rela. In the expert panel today, we have Professor K.M.J. Zaki, who's the head of the Department of Hepatology at Sylhet Osmani Medical College and also the Dean of Medical Faculty at the Sylhet Medical University. We have here, as said, Professor Dr. Harunur Rashid from Rajshahi Medical College. We have Dr. Muhammad Abdul Rahim, as said, Professor of Hepatology at Abdul Malik Medical College. We have here Dr. Ashraful Alam, who's an associate professor of hepatology at Tajuddin Ahmed Medical College, Ghazipur. And we have here Dr. Sheikh Muhammad Noor Alam, who's an associate professor of hepatology at the Bangabandhu Sheikh Mujib Medical University. So we'll go back to the panel of experts for their comments after Professor Mohammad Rela's talk and after the question and answer session. So without any further delay, it's my pleasure now to invite Professor Mohammad Rela to speak on how to run a transplant center during the COVID pandemic. In his talk, he'll give us an overview of the COVID situation and then on the transplant situation in his Center of Excellence in Chennai. Thank you very much. Professor Rela, please.
Thank you.
Professor Rela, if you please unmute yourself.
Sorry. Thank you. Thank you very much, Professor Mamoon, for this invitation to interact with the hepatologists and the doctors in Bangladesh. It's a pleasure. We have actually gone through a very tough time in order to run a transplant program. I just want to share our experience. I, as you know, also run a hospital at the moment, not just a transplant surgeon. And there have been huge implications of the importance between running the two parallelly. There have been many issues with relating to that. And I just want to share our experiences of how we have gone through. I'm not actually telling anybody how to run a transplant program, but there isn't any precedence for this. So we went into it. We got into trouble in some ways. We have come through it and we have stabilized now and just want to go through our experience that way. Let me just share my slides first. So now I know all of you have are experiencing it, and I don't know where you are in the pandemic. Yeah, it's not moving through that. Through the pandemic now, I think this is today's data, almost 12 million cases worldwide, more than 500,000 deaths worldwide. India is actually ranking number 3 in the world currently with 780,000 cases. But what's been good about India, which is a little strange, and is the mortality in India has been quite low compared to the European countries and the North American countries. The South American mortality is also slightly lower compared to the European countries. But there are some contradictory things. When I say this, most people would say that the data from the Indian subcontinent may not be accurate, the death rate may not be accurate. But I don't think it is purely not recording the data. I do believe that we are fortunate that the mortality rates are low. There are many reasons. I think one of the reasons is I think we have got into this problem quite late compared to the Western world. I think if we had this issue 2 months ago or 3 months ago at the beginning of February and March, we would have seen many more mortalities. And I think the understanding of the disease has improved enormously. And I think we are able to treat patients very effectively. From really very early on, this is a publication earlier on where the Chinese have really divided it up. And we know that majority of the patients, 80% of the patients will have mild disease and they will get through. And many of them may be in an asymptomatic stage or in a pre-symptomatic stage. So a lot of patients actually don't have to come into hospital. And there are many patients who suffer from the illness not knowing at all and would never have a test done until somebody is a contact from them, and that's how they get the test done. But our concern is really the severe patients and the critically ill patients who are managing in our hospital. Now, there are many comorbidities, and this is the most recent Nature publications, which really defines the hazard ratio or the risks. I know the slide is a little tight, but there are many information here. And what is strange when you see in the ethnicity in the Western population, Asians have double the risk than the Caucasians for the risk of death. And again, Black population have a higher risk of death in the Western world than the Caucasian population. But when you look at the mortality in Italy and UK, it's more than 10%. Between 10 to 15% is the mortality in the Western world. But the mortality among them in the Asian population is much higher. Then why is it that the mortality in the Asian countries itself is lower, which is a question that we need to address really. I mean, there are many postulates about it. Maybe I think that we are managing them much better than they would have managed in the Western world, because the understanding of the disease was very poor, and I'll talk a little bit about that. But also now there is some association with vitamin D deficiency, and the Asians living in the Western countries are probably more vitamin D deficient than the Caucasian population itself, because they require the sunlight and they're not getting the sunlight, and there may be some risk factors like that. But what is of interest for us as you come down, obviously uncontrolled diabetics have almost twice the hazard ratio. But when you come to patients with chronic liver disease, they have a much higher risk of dying if they were to contract COVID-19. And also organ transplants is probably the worst of them all, which is hazard ratio of more than 4%. And there are some studies about how they are performed in terms of whether early in the post-transplant period or late in the post-transplant period, the risks have been quantified. I'm not going to go into the immunology, and the virus really binds to the ACE2 receptors. And the receptors, this is a respiratory virus, even though the receptors are not so highly concentrated in the lungs, because the route of entry is a respiratory virus, the lungs are affected more. But it is a multi-system disease, because we have seen many patients with myocarditis, as you all know, that they affect the GI tract, and gastrointestinal symptoms like diarrhea are a common manifestation of COVID-19. So the thing to remember is that it is a multi-system disease. And I see this disease as a new disease, which I think every doctor should be familiar with. This is not something which should be confined to a respiratory physician or an infectious disease specialist or a general physician. Actually, we have the numbers are so huge, and I felt that, at least in our institution, I felt that every clinician should get involved. And I've always told the doctors who are not involved immediately in the care, even the surgeons, to tell them that if you don't manage COVID, and 10 years later, if somebody asked you, if your children asked you, how was it during that pandemic? And for a doctor to say, I've never seen a patient, never managed a patient with COVID-19, I think would be an extraordinary statement to make, because this is going to be a once in a lifetime experience for us. And it's such a difficult time for the medical profession. I feel that every doctor who's going through the medical profession at this time should understand and learn about this disease completely, really. Now, you would have seen that the news that came from particularly Italy, where the intensive care, you would have seen pictures of doctors talking from intensive care, and they are all saying that this is not like a pneumonia. This is not like a viral pneumonia. The patients initially don't look sick at all, but they are very hypoxic. And then suddenly they collapse, and a lot of them are ventilated and they died. And the mortality of patients in intensive care were extremely high. In the early stages, almost 50% mortality for ventilated patients in the Western world, which would have been unheard of. And part of this problem is really not understanding this. I mean, looking at this like any other respiratory virus, and pneumonia was the initial mistake. So it does everything that a respiratory virus does, and you get the cytokine release, you get edema, and there is very poor gas exchange because of the alveolar component of the disease. So it does everything like a respiratory virus. But what it also does is it also affects the perfusion component as well. The circulation is also affected in this, which really came up much later in the course of the disease, that they were detecting thromboembolic phenomena in these patients. More than embolic, I think COVID-19 is a procoagulant condition. You can have thrombosis in the peripheral vessels, you can have DVT as well. But actually, there is a thrombotic element within the pulmonary microcirculation as well. So it's because of this, there is a combination of poor ventilation because of the alveolar component of the disease, as well as poor perfusion because the circulatory system is also blocked up. So you get very severe hypoxia in patients who don't apparently look very sick. So until the later stages, it's a single system illness that you see that is very, very difficult to manage in the early phase of the disease. Now, in the course of the disease, and I was speaking to Professor Mamoon earlier on, that many people have now decided that they can be managed at home with some clinicians, even see WhatsApp messages as to what drugs to take, what to do, and people are buying these pulse oximeter and staying at home. And there are even suggestions that you should have an oxygen cylinder at home because you may not get a hospital bed. And we went through a phase where people were desperately looking for hospital beds, and it became a very scary situation. But that is changing now. I think in Chennai, at least at the peak, we were having around 2,400 patients a day. Currently, it's dropped down to 1,200 patients a day, and every hospital is now admitting, almost every hospital is admitting COVID patients. And so the point to remember is 85% of the patients obviously will recover and will have minor symptoms, but it's the 15% of patients that we need to talk about. And I believe that when patients actually have severe respiratory symptoms and are actually getting hypoxic or understanding that they're getting breathless and walking, they should be managed in hospital. Really, I think the understanding and the treatment protocols currently will prevent them from getting into the ICU and being ventilated. I think the point of management of these patients is really to stop them from being ventilated and appropriately managing them so that they can get through. And I can tell you in the last 6 to 8 weeks, we've learned enormously that if patients come to us early with comorbidity and become hypoxic, it's very rare that they will get into ventilated. So in the last 2 months, really, we have managed about 650 patients, well over 650 patients, COVID patients in the hospital, majority of them really with moderate severity. Almost, I think, 30 to 40% of patients who are admitted require oxygen therapy once they get admitted. And we have allocated about 15 to 20 intensive care beds. And in the early phases, really, it was a struggle. What I did was, everybody said we are a transplant hospital, and therefore you could get an exemption from managing, because the government actually passed a rule that every hospital should allocate 25% of beds. Every private hospital should allocate 25% of beds for management of COVID patients, and we readily accepted that offer in a very, very early stage. And I told our doctors, many were really worried that we were getting into really managing COVID patients. And I thought, first of all, it's a responsibility for the society that we live in and for the local population that we manage patients with COVID. And the second point that I was saying to our doctors is, if we get infected and if our family members get infected and if the doctors and nurses get infected, I didn't want to be at the mercy of really other private hospitals or the government institutions. So I very strongly felt that we should really manage these patients within our hospital. And we really got into the treatment protocols, and we wanted to understand the disease really. Every day we had a kind of a CME where one person was given a topic, and we set up our own protocol, which was advantageous because the government also were coming up with protocol, which was probably about 1 week a lag time for government too. And I think the government protocol in Chennai and Tamil Nadu is also very robust. But we actually got into it much earlier than the government protocols. There were some worries that we were trying to do things much before what the government was trying to suggest. But I felt that it was very important. We had almost a series of 15 lectures over a period of 2 weeks in deciding what is working and what is not working. And we abandoned really hydroxychloroquine and azithromycin very, very earlier on in our patient management. Before going into really what we did and kind of treatment, I think I'm only going to touch the basics of treatment that we have followed in our patients. But what I would like to say to you is the general rules are still very important. The physical distancing, even within the hospital, within our own staff, within our own people working in the department, how they share the spaces in the canteen, how they share the spaces in the offices is still very important, because if one person gets infected, many other staff within the department will get infected, and isolating them continuously for 2 weeks is going to be very difficult to run transplant programs, because we have almost 30 doctors working within our transplant program. And I say to them, they still have to wear masks, they still have to eat independently and not join together to have meals together. They still really, when communicating with each other, have to worry about whether the other person is infected or not. And that is so both for the patients and for the doctors and the nurses who are working together. Actually, that is what is going to prevent really patients and doctors getting infected. And there are many hospitals in Chennai which have closed down because they have had 50 doctor or 50 staff infected, 100 staff infected. In almost every government hospital, there has been a huge amount of staff infected. And I would say we were very fortunate. I think we have, among the people who have worked within the COVID ward and the A&E department, so far we have only had 4 doctors, 4 staff, I mean 3 nurses and 1 doctor who actually got infected. And we have got away without any major spread of the disease within our hospital. Now, there are really very, very many treatment options available, and there have been a huge number of publications which have come about. And I said earlier on, chloroquine or hydroxychloroquine now is not in any of the recommendations. They've been removed, and there is quite a bit of hype about it. And there is also quite a bit of hype about the toxicity of hydroxychloroquine, which we found very difficult to understand, because Chennai itself has been a malaria endemic area, and these drugs have been used by GPs like water really, and it's never been an issue, but now they are out of question. Azithromycin and hydroxychloroquine combination is actually harmful, and it's been taken off from the system. Now, coming to the antivirals, really the evidence, the strong evidence for usage of antiviral for every patient is not there. Remdesivir really has become available to us, freely available. I mean, it's been available on a patient basis, or influential patients have been able to acquire it from ICMR and from studies and things like that. But generally, it's become available really freely only in the last 2 weeks. And I would say less than 10% of our patients have had remdesivir. And I don't believe it has made a huge difference, but there is some evidence to suggest that remdesivir is useful in reducing the course of the disease. Now, what we need to remember about antiviral is there is no point giving antiviral when the patient is in ICU and ventilated. By this time, really, the viral shedding has significantly reduced, and even people get desperate when they are really very sick. The time to give antiviral would be in the infective phase, immediately after the onset of symptoms, if they are going to require or going to become hypoxic. It's really in the first week of the illness that antivirals need to be used, rather than when the cytokine storm and the inflammatory phase of the disease and the later phase of the disease is not when antivirals need to be used. It's really in that phase, you're better off using anti-IL-6 and anti-inflammatory medication in the later phase. But I think the rest of the antivirals have not been really found very useful. In the early phase, we did use anti-IL-6 antibodies. Mainly, we used tocilizumab, but we have abandoned using tocilizumab. Not many patients are becoming that sick to require it, and we have been using it in the intensive care setting. And there is clearly evidence that it also increases the risk of secondary infections in these patients who are stuck in a ventilator for a long time. Now, again, convalescent plasma, there is some interest in it, and we probably used it only for about 4 patients. Again, it's not something that is very, very widely used till today. But what has changed? We saw in the pathophysiology really of the COVID, there are 2 things that happens. One is the severe cytokine release and the inflammatory response that it produces. But the drug that has really changed is corticosteroids in the form of dexamethasone. We use 8 milligrams per day of dexamethasone. The recommendation was 6 milligram. I believe that the Indian 8 milligrams dose is equivalent to the base salt of 6 milligrams that is available in the Western countries. And I would say 10 days. And this is started on any patient who actually is starting to require oxygen. So we start all patients, or at least if their inflammatory markers are exceedingly high, or if they're starting to require oxygen therapy, it's the time we start using corticosteroids. And dexamethasone has certainly stopped many patients from progressing on to the intensive care. So this is why I say to people that are managed at home that they should not be waiting breathless. The patients we lose currently are the patients who come in breathless with 4-day symptoms, severely hypoxic, even with 10 liters, they have their saturation below 90%, are the patients who very rapidly go into intensive care and get ventilated. And the outcome of these patients are very poor. So I would suggest that you advise your patients that as soon as they start getting respiratory symptoms, severe respiratory symptoms, they should come in for really treatment with corticosteroids. And the other thing that has made a big difference to these patients is prevention of the thrombosis. So you are affecting the alveolar side by reducing inflammation and improving gas exchange with corticosteroids, and you're preventing the thrombosis on the perfusion side. So I think these two drugs, if you ask me today, if any difference in the outcome for the patients with COVID, it's really the anticoagulation. We use Clexane initially as 40 milligrams once a day dose, and in those patients who are very high risk or who have high markers, we almost use 40 milligrams BD dose or 60 milligrams once a day dose. So variably depending on the weight of the patients. So I think the combination of corticosteroids and the anticoagulation, I do believe has made a huge difference to the outcome of COVID patients. And I think antiviral really only comes third. Now let's come to the the concern for you as a hepatologist. I think in the early publications, really there was evidence. The evidence was there is actually no concern, even though the ACE2 inhibitors are expressed in the biliary epithelium. There was very few patients who really were hospitalized patients, were unwell. So the general impression in the early publication was that it wasn't a concern. But later on, there is now more and more emerging data that patients with pre-existing liver disease have a much worse. We saw that the risk was 2, but our own experience in our patients has been poor. Our hepatologist, Dinesh, was fortunate to really review all the data on COVID and liver, and has had a publication actually in the Journal of Hepatology. We are quite pleased with that. And we have now found that patients with decompensated chronic liver disease who get infected with COVID in hospital, if that happens in hospital, they have a very high mortality. In-hospital mortality is extremely high. And that literature is really coming up. The 30-day mortality of cirrhosis and COVID-19 is also found to be very high from other studies as well. And, Dr. Sareen has been collecting data on patients with liver disease or with transplantation, and a combination of all of that. And again, their suggestion has been, and this is recently published in Hepatology International, and I think they're continuing to collect the data. Now, what about continuing a transplant program? And what are the worries about continuing with a transplant program of the COVID era? I think the first reaction for me, we were really, I think some of you may have been in the MCLD meeting that we conducted in the end of February. And in the beginning of March, we were happily transplanting, thinking that this is not going to be a big problem in Indian subcontinent. They were saying that the temperature is such that the virus is not going to be bad in here. Summer's going to come and it's all going to disappear. So when we started, it was, we were just transplanting. But when the data emerged, because we were doing living donor liver transplantation, and I'm not sure, this is an international study about patients getting infected in the perioperative period. This is not about liver transplantation. This is not about hepatectomy. This is any operation. It was suggested that if you perform any operation and if the patient acquired COVID-19 in the perioperative period, either immediately before or after the operation, they had a 50% postoperative pulmonary complication rate, and they had almost 24% 30-day mortality. Nothing can be more scary than this data. This is a multi-center data from the European. I personally don't think that this is applicable anymore, because this data came from the European countries where the general mortality was already more than 10%, 12%. And I think in countries like one of the countries in Europe was almost more than 15%. So they are saying that if you do an elective operation or an emergency operation on a patient, and if they had a perioperative COVID becoming positive, that carried a 24% mortality. If this data was applicable today, we will never be able to do a donor operation, because donor operation is much bigger than any elective surgery. And if they contracted COVID in the perioperative period, then they carried an extremely high mortality. This is data as it is, and I'm not challenging it, because this is published in really Lancet. But I don't know how applicable it is in the current situation, really. So this was from 510 hospitals and 60 countries this data was collected from. Now, as a result of that, there was a huge drop in elective surgery, really. The elective surgery dropped around 30%. The emergency, 80% of elective surgery were cancelled, and really 70% of colorectal, the cancer surgeries were cancelled because of this study, because of the fear of getting COVID-19 in the perioperative period. Now, we were dealing with a much, much riskier proposal of continuing a program with the living donor liver transplantation at a COVID era. And in the early March, we didn't know how the liver was going to be affected. The healthcare system, we didn't know whether we were meant to be taking COVID patients or whether we should continue with the transplant program. And does immunosuppression affect these patients? Do patients who are on immunosuppression, will they have a very high mortality? None of this, whether we should be doing DDLT, and when you go for a DDLT, how do you assure that the cadaver donors are not infected? Because you can't be doing COVID tests. And in the early phases, the tests were also not very freely available. There was a huge restriction. And they had indications for doing the COVID test as well, and it had to be done through a prescription. So really, there were many recommendations which came from ASTS and AASLD, and all of this really resulted in somewhat stopping living donor program throughout the Western world, but they were still continuing to do the disease donor liver transplant program. And there have been mortality among surgeons who contracted really COVID-19 from donors. There was an Egyptian surgeon who died in the UK because he contracted from a donor. So it was really a very scary situation, and you can see the UK data at that time from really the beginning of March to the end of March to the beginning of April. The transplant program really came to a standstill, other than for really acute liver failure. And India, really, the thing about India was they went on a lockdown, and they went on a complete lockdown like nowhere else, really. And because of really the fear, and really it started in the middle of March, India went on a complete lockdown. And once you go on a lockdown, and for a transplant program like us, the local patients for us, like Chennai patients, was probably only around 20% of our patient population. Tamil Nadu would have been around 30% of our patient population. The rest of India, like patients coming from Northern India, from Calcutta, from Hyderabad, Kerala, they constituted around 1/3 of our patients. And 1/3 of our patients were really overseas patients, like the Middle Eastern patients. We had a contract with Oman, with Bahrain, all government-sponsored patients from these countries were coming to us. So after the lockdown, everything really stopped. There were no more patients other than the only patients you could have or the sick patients within the Chennai, because patients could not even move from one district to another. And in fact, we were actually outside the borders of the Chennai district. And I had difficulty traveling from home to the hospital because I had to cross 2 districts, because my house was in a different district and the hospital was in a different district. So actually, everything came to a standstill. So when we looked at the statistics and we started, so in March, really, after the 15th of March, I'll tell you, until the 15th of March, we were extremely busy. And with the lockdown, we just stopped operating. And then in April, we restarted. And that was a case when every big hospital in India, they all really stopped operating. And the Liver Transplant Society of India also came up with recommendations to say that you should not be doing elective LDLT anymore. And there was a moratorium on all non-urgent transplant. And once the society comes and tells you, you can't do transplants anymore, our hands were completely tied. There's no way we could do. So how did we go from this point? And I want to travel back to the middle of March, where after the MCLV, this is starting from the beginning of March. This is just to show the number of transplants we did. So if you look at the 1st of March, immediately after the tall line indicates 2 transplants in a day, and the short line indicates 1 transplant a day. So that's how busy we were. So the 1st, the 2nd, the 3rd, we were doing 2 transplants each day or 1 transplant a day until the middle, the 15th and the 19th of March came, and we were on a lockdown around the 20th of March, and everything came to a standstill. And we didn't know. I was sitting at home for almost 15 days and just doing ward rounds through webinars and this and that and discussing with people, and everybody was scared. So I think it's the same slide to show what the weekly numbers are. Now, middle of April, we made a decision. We spoke to the Liver Transplant Society of India and say, we have many patients, because we had some of the patients had come from Northern India who had worked up and were ready for a transplant. Many Middle Eastern patients were still stuck with us following the lockdown. We were not able to give them a date. So we started again on the 14th of April, and we did 5 transplants. You will see from the earlier statistics, we did 5 transplants, living down a liver transplantation very carefully, and I'll tell you what happened. And the 6th transplant was a child, 7-year-old with Wilson's disease, and a 26-year-old mother. This was an acute liver failure, and the mother wanted to donate, and we did the workup on the mother. We did just 1 COVID test really on these patients the day before surgery. She was totally asymptomatic, and she became positive. And she was positive, and she had exposed herself with almost 40 to 50 the doctors, because the transplant assessment involves really every specialties, the nurses, the coordinators, and so many people were involved in the care of her. And we had to stop the program once again at this point. And at the same time, in our hospital, we had 2 patients with decompensated chronic liver disease who were actually in our hospital for about 5 or 6 days. And their chest CT showed suggestion, they had chest symptoms, and that showed suggestion of COVID. And we tested them, and they again became positive. Now we had 3 patients in a row in our hospital who were positive, and we were not admitting COVID patients at this point. And the government, these was the very early days, the government got very excited, and they thought we were giving COVID to our patients. And they made us they stopped the program, and they made us test all of the people involved in the care of these 3 patients. And there were more than 200 clinical workers who were looking after these 3 patients. And we tested all of them, and not one doctor or one nurse looking after this patient was positive. So that gave me the strength that if you take the normal precautions that you take, because we gave them all N95 masks, and our ICU staff were always wearing an apron, they were wearing a gloves, they were wearing a cap and a mask. And they were looking after these patients just like any other patient, and not a single healthcare professional in our hospital at that point got infected. So I felt that if we take proper precautions, it is possible to continue with the transplant program. And so we put in place, and at this point of time, really, we separated the hospital into two. The A&E entrance and the top floor of the hospital became really the COVID hospital, and the rest of the hospital became a transplant hospital. And we managed patients, and I saw really patients on electronically only was managed these patients, and through really what we're doing now is how most of the doctors, other than the ones on the floor who are looking after them and looking after them in the intensive care. So we made a huge number of changes, and we restarted the program really. This time we were doing only one transplant a day. In May, we restarted the program. And after restarting, I think now we have done, from middle of May to now, probably we have done around 20 transplants, I think. And this time again, it's not that this is not going to happen. We had done 14, I think 12 transplants. The 12th transplant again, the donor was positive once again. But now, because we were prepared, we were able to continue transplanting donor. I mean, people usually make a mistake when I say the donor is positive. The donor did not become positive after the operation. These are donors who were tested prior to the operation. And we also, what we did is we now did 2 tests. When patients come into hospital, actually totally there are 3 tests done. Before the transplant workup, they have a test done. And then when the transplant workup is done, 5 days, -5 day, they get a test done, and -1, the day before the operation, they get another COVID test, RT-PCR done, so that we are not missing them. Because previously we thought if you just did it 2-3 days before the operation, they could still be in an incubation period and become positive after the operation. But if you did it 5 days before and then -1, they would have gone through the incubation period, and therefore only if they get infected, it's only possible if they get infected post-operatively in the hospital. And because we took precautions, we were able to carry on with the program. And now we are really continuing the program. But still, there is always a worry that there have been reports that donors have got infected in the post-operative period. I think there was another hospital in our city itself where the donor and recipient got infected. Fortunately, both of them survived. So this is a very calculated risk, and unless you put in place a system where you're going to protect the donor and recipient for the first 2 weeks after the operation. And there are many reports coming of even in children. There is one where there was like a hepatitic-like picture from COVID-19 in the post-operative period, and you will see. And there is also fatal outcomes in patients with 3 years post-transplant. We had a patient who was admitted who had a transplant 15 years earlier in the UK. And he was actually a member of the Legislative Assembly, a very powerful individual who had a transplant, liver transplant, and admitted in our hospital with severe pneumonia and died in the post-operative period. And we saw earlier on, actually, the risk for patients in the post-operative period getting COVID-19 is very high. And there have been many cases, and the registry data actually suggests that patients who have had a transplant greater than 10 years before have much higher mortality than patients who get the illness under 2 years after transplant. The understanding is because these patients are still on higher immunosuppression, they are still on steroids, and therefore the immunosuppression and steroids are probably protective. So if you see this number, 111 patients in COVID in patients who have had liver transplant greater than 10 years, the mortality is 3%, which is really lower, or it's the same as general population. And the patients who have had transplant in less than 2 years, out of 40 patients, there has been no mortality. So really, it's not so dire. And the data on the post-operative acquisition of COVID-19 and the high mortality, I already think is probably a historical data, and I hope that we won't see such mortality anymore in the COVID patients. And we have to thank God that the disease and the illness came to us at a later stage than in the earlier stage, rather than directly coming from China to India when our understanding would have been poor and our management skills would have been much poorer compared to what it is now. And I think we have been protected, that the disease has come to us much later, and that we are in a much better position to look after these patients, and we've reduced mortality significantly compared to the Western population. I think I stop there. Thank you very much. Sorry, it's been a long journey. I hope I've not bored you too much.
No, it was very interesting, actually, Professor Rela. The usual lectures that we see, rather than this being a mixture of academics and your own experience, your center's experience will be highly effective for us, useful for us. Now, there are some questions for you about one thing, that whether you will be using remdesivir in a later stage or not. Keeping in mind that the USFDA has given the approval, for emergency use approval for late stage cases. So what do you think? You have said that you wouldn't prefer using antivirals in the later stages, and I agree with you. But again, what would you see about remdesivir? There's also another question, whether you are using remdesivir and IL-6 in your center in late stage patients.
Okay. The first thing to say is, I think remdesivir is a good drug. There is enough evidence to suggest that it reduces the course of the illness in COVID-19. So I'm all for remdesivir. And if it is freely available, in fact, I would start using them the moment they require oxygen. So I would use them actually in the very early stages of the disease. Because it's available to use, I think you should be using. If you ask me, will you use it in the later stages of the disease? Of course, if the patient has not had remdesivir in the early stage, and if they come to hospital late and they are stuck in ICU, I would still use remdesivir. It's not a contraindication. Because when you looked at the pathophysiology of the disease, the viral component of the disease causing illness is in the early stage of the disease. Later stage of the disease is actually driven by the inflammatory cytokines. And it's not really, people even say now that after 10 days or 12 days, they are, even if they are PCR positive, they are not infective anymore. So ideally, if you have an opportunity to use it, if the patients come to you early, you should use them in the early stage, I believe. I believe that early stage in the sense, not asymptomatic patients. The moment the patient starts to require oxygen or becoming hypoxic, I think they should be given at that point. But if they come to you at a later stage and they're already in intensive care, absolutely, I think remdesivir should be used in the later stage as well. Because there are still many unknowns. You don't know that there may be some patients who may be really replicating the virus even at the later stage, and that may be driving the cytokine storm. So it might help. And there are people who also would use at that stage convalescent plasma really to reduce the viral load at that time. So maybe there may be an element of virus still driving the inflammatory response in the later stage. So who am I to say it doesn't work? I do, but the literature suggests that it works less well in the later stages of disease. But that doesn't mean we should not give it, because it is a safe drug and I believe it should be given. If it was me, I would still give it.
So the early use of antivirals, one indication someone is suggesting would be to prevent the transmission of the disease. Because if someone has early virus, even if he is asymptomatic, at least to spread. Although it is true that if someone is in true isolation, they won't spread. So how would you rank favipiravir, the other drug,
That's a very that's a good suggestion. It's a very clever suggestion, because it applies for all viral illnesses. For example, I can quote an example that when patients with HIV in the early stages came for surgical procedures, we would load them with antivirals just before the surgery. So they become less infective during the surgery. Okay, even though they've been on standard treatment, we would actually give them more treatment at the time of surgery when there is an exposure to somebody else. So it's the same principle. The problem has been that until now, the drug has not been very widely available to give it in order to prevent the spread of the disease in the early stages. But if the drug is very freely available, I wouldn't mind, then that means it's an injectable preparation, isn't it? Are you suggesting that?
Favipiravir is oral drug. Favipiravir is an oral drug. The Avigan, the Japanese.
Yeah, but there is no evidence for favipiravir actually. There has been a huge hype about that drug, maybe because it's an oral preparation, but still in the literature, there is no evidence that it is a very useful drug for treating COVID-19. We have not tried that drug at all. But I believe in remdesivir, and if it is available, I think it's worth giving for early patients. And now you're talking about giving it to even patients at home then, in order to prevent reduced viral load.
Favipiravir, not remdesivir.
Oh, okay. That's fine. That's okay. Yeah, but the evidence for that is quite not very convincing yet.
So another question is there would you prefer methyl? Is there any suggestion that methylprednisolone will be better than dexamethasone?
Yeah, we've had that discussion. Methylprednisolone can be given at a much higher dose. If you look at the recommended dose of dexamethasone, it's only 6 milligrams or 8 milligrams, which is an equivalent of about 30 milligrams of methylprednisolone. When we give methylprednisolone, the recommended dose is 1 milligram per kilogram body weight, so which is almost 60 to 70 milligrams. So when methylprednisolone is given at twice the dose, it's fast acting, and its concentration is much higher in the lungs. But we can't ignore the fact that the study that came from the UK, the Birmingham study, which has dramatically reduced mortality with dexamethasone, 8 milligrams. So I find it very difficult to, initially we were giving methylprednisolone, and there was some subjective, we actually looked at the data, the mortality data. In fact, we used methylprednisolone early and then dexamethasone later. But in the early, we had a slightly higher mortality because there were other hospitals who were pushing higher the sicker patients into our hospital because we had a bigger intensive care facility. So the data got very screwed up, really, because our doctors felt that if you gave methylprednisolone, the lung symptoms improved pretty dramatically compared to dexamethasone. So the patients took longer to come off oxygen with dexamethasone than with methylprednisolone. That you can understand because it's double the dose, obviously. But if it prevented death even at the smaller dose, even though it's given for longer time, does it matter? If higher dose of methylprednisolone caused more septic complications, did it matter? So I stuck to the principle that I will give dexamethasone even if it actually takes longer for them to come off oxygen, because it's still not pushing them into the intensive care. It is still not making them ventilated. So I really made that decision. We'll stick to dexamethasone rather than methylprednisolone. But what I did, when patients presented acutely to A&E, I gave them their first dose as methylprednisolone. The A&E itself, when somebody requires oxygen in accident emergency and they're getting admitted in the middle of the night, because dexamethasone is a much, much slower acting drug. For its effect, it almost takes 4 hours. So I've used that as a combination. So they will get their first dose if they require oxygen in A&E itself, 1 milligram per kilogram dose of methylprednisolone. And if they are stable, then we continue with dexamethasone. But I've got nothing against methylprednisolone. If people want to use methylprednisolone, perhaps they can give a shorter dose, maybe 5-day course is 1 milligram of methylprednisolone, rather than 10-day course of dexamethasone at 8 milligrams dose.
So we have questions about convalescent plasma. So
yeah,
what is the role of convalescent plasma in the later stage of the disease? When we are not very sure that virus has anything to do at that stage, when cytokine storm is playing the role, then is it the antibody in the convalescent plasma that is doing the trick, or is it the plasma from the receiver, from the donor, that has no cytokines, that is doing the trick, reducing the cytokine bulk? And if that is the case, is there any role of plasma exchange? What do you think?
Yeah.
I go for convalescent plasma. Why not plasma exchange?
Yeah. Okay, the first thing to say is it's not the plasma without the cytokine that is improving, because the dosage of convalescent plasma is only about 200 ml. It's a single dose which is given actually. So in that way, it's very different from plasma exchange, which is a continuous exchange. We have actually, we discussed about plasma exchange. There have been some publications, but there has been no convincing evidence for TPE actually. The problem with convalescent plasma is because the treatments are so well established now. In the early stage, we give them corticosteroids, we give them anticoagulation, we give them remdesivir. So the plasma is actually has taken a backstage unless we wait for there are many studies still going on, unless they say that it's made a dramatic difference to patients. Because for the usage, you see, in the early phase when we were doing this, they said you have to wait for 1 month from a patient to take plasma. They have to have antibody levels. They should have had significant symptomatic disease. And then only you take their plasma and give it. And we didn't have patients who are 4 weeks old to get the plasma. Now we have. Now we have many patients who are willing to donate. I mean, I have to say a lot of patients are not even willing to come back to hospital to donate. That's another thing. So it's not left us with a window where we want to give, because we're doing extremely well with the corticosteroids and the anticoagulation and the remdesivir. So we are only left with giving convalescent plasma to patients who don't actually improve with this treatment and land up in intensive care. You understand? Then only then we think about what else to give, and then it is convalescent plasma. And convalescent plasma to give at a later stage of the disease, as you say, when it's no more a virally driven disease, it's a cytokine driven disease, is it going to be helpful is a question. So it's not really an active process. I think if we make a decision to give convalescent plasma, just like remdesivir, I think we should decide to give it early. Unless you do that, you will not know whether it's going to work or not. But unfortunately, we are set in how we are practicing now because it is working the way we are practicing now. And only situation where we are thinking about convalescent plasma is when this treatment option is not working and the guy is getting sicker, and we are saying, what else can we do? And then we give them convalescent plasma. And that is not going to help the cause either. And it's not going to prove anything. But fine. I think when we've got nothing else to do, I think it is something which is still worth exploring. Just like I said, giving remdesivir at a late stage, convalescent plasma should also be considered at a late stage because we've got no other option.
So, have you two questions? You have shown in one of your slides that patients who have had more recent, have been transplanted more recently, less than 2 years back, have better survival with COVID, possibly because they are receiving steroids.
Yes, possibly because of their level of immunosuppression. It's probably higher. And patients who are long-term, 10 years post-transplant are on very little, very minimal immunosuppression. So it's the same, like corticosteroids helping these patients, maybe the level of immunosuppression will help to reduce cytokine storm in these patients. But that's only an explanation. But the finding is true that early post-transplant patients have done well. I'm not talking about perioperative patients. Perioperative patients may not.
So if that is the case, why not start steroids early? What we are of the opinion that if we start steroids early, it will reduce the immune status of the patient, and in that case, the innate immune system will not be very effective against the virus in the initial stages when it's a viral-driven disease. So, is there a bit of
I agree with you. I'm not completely against starting steroids early, but we need to have some point where we start, because almost 80% of the patients may test positive through contact tracing, and they're asymptomatic. See, if you're asymptomatic, you're not going to have a test done. So there are many patients wandering around with COVID-19 positive, but not having the test and not being symptomatic. You leave them alone. But the patients who are going to be asymptomatic and tested positive are usually tested through contact tracing. Somebody in the family has symptoms and they test positive, and we test everybody else in the family and they're all positive. Now, these patients also don't require any treatment. Majority of them will recover. So if you say that we have to start steroids in the early course of the disease, then which patients do you want to start in the early course of the disease? Do you want to start the asymptomatic as well is the question, which is why we decided that we start steroids at a time when they know that they've got an inflammatory response. And that is when you require oxygen, very early in the phase. Or you could do something else. You could do inflammatory markers for them, which we do on the day of admission. And if the inflammatory markers are high, obviously they are a high risk. You can do IL-6 levels, and then you start them on steroids. I have no problem with that. I believe that starting steroids early does help. But the problem is, then do you start everyone who tests positive, which is practically not possible and not necessary, which means you're going to be treating almost 80% of the patients who don't need steroids with steroids. So I think you have to fix a point, find a reason.
As I was listening to your discussion, something that haunts me all the time, there is this saying in the among our people that people in our part of the world, having been exposed to pathogens for so long, have developed immunity, the reason why we are dying. So I always wonder, it is increased immunity or decreased immunity that is saving us. What would you say?
It seems that both are helping. The increased immunity is preventing us from getting infected. The decreased immunity helps you when you get infected. Okay. Is there anybody? Yeah, go on.
Actually, when I think of the disease, I fully agree with you. This steroid and anticoagulant. And the other thing I think is the use of antibiotics, which is in some cases we go for that prophylactically or earlier than the Europeans. This is possibly something that is preventing secondary bacterial infection, which I think may
that's also, I think we also start antibiotics once they require oxygen prophylactically. I think but the Western world is very resistant to starting antibiotics. The early phases there, we actually wrote an article in the early stage saying, is India going to escape? And this was all the same thinking, we have got hot summers and therefore, flu is not a problem in our part of the world. Flu is a big problem in the Western countries. We don't get admissions into ICU from flu. Therefore, we are protected from respiratory viruses. And then we were saying, hydroxychloroquine works well. In our part of the world, which is endemic for malaria, the drug is prescribed widely. And it's a drug with very long half-life. I think even after 3 months, you've got some element of the drug inside your system. And maybe that is protecting us. And then they say BCG vaccination is protecting us. Then we are exposed to so many viruses. Our chief minister even went and said that it's a disease of wealthy people. The poor people won't get because they've been exposed to so many different viruses. So all of this hypothesis is, it's wishful thinking on our part to think it's not going to affect us. But it's now affected us. We have to live through it.
So thank you. The last question to you is that someone is asking if you have any opinion about the combination of ivermectin, the Japanese antiparasitic drug, and doxycycline, which is very popular in Bangladesh.
No, I have no experience actually. We have not tried it on any patient. We have not used it on any of our patients. Ivermectin with doxycycline. No, we have not. Doxycycline sometimes we have used as just for prophylactic, as a prophylactic antibiotic, but I have no experience on that combination.
So 1 or 2 more questions have come. What will be the target oxygen saturation to start steroid or remdesivir?
95%, below 95%, you would start with 2 liters nasal cannon.
And IL-6, IL-1 inhibitors for cytokine storm, what do you think?
We have used tocilizumab in the early phase of the disease, and we still use it in patients with ICU if their IL-6 levels are skyrocketing. but I don't think we have found it very useful. But we have used it.
That is tocilizumab.
Yes.
So I think that's the questions that I have that we had, but I must tell you that we have been having series of webinars. This pandemic has created a pandemic of webinars also, but I have hardly found any of the webinars so academic and so enlightening. I was not expecting this type of discussion from a transplant surgeon, if you ask me. It's really amazing. It shows why you are Professor Mohammad Rela.
Oh, thank you. No, we had no choice. We had to do this. We had no choice. We have to learn about it. You know, we can't just say, I'm a liver transplant surgeon, I'll go into hiding and then come back when everything settles down. That wasn't an option at all for us. We had to do it, and I think we have done it well. And I want to thank all my staff for being so brave, and everybody has been involved. And what is good is everybody who's worked in the ward for a week has come out and said it's been a fantastic experience, because it's an opportunity for everyone to do that.
From our experience, we also, I think my colleagues will also agree that it is the hospitals where there is a half-hearted approach to COVID management. There the doctors are getting infected.
Yeah, absolutely. Yeah, you're right.
COVID hospital, people are safe. It's a non-COVID hospital, people are safe. When you do both and you're half-hearted, not trying to take patients, then it solves the problem. So thank you. Now going back to our panel of experts, I'll first request the opinion of Dr. Professor K.M.J. Zaki. As I introduced him, he is the head of the Department of Hepatology at Sylhet Osmani Medical College and also the Dean of Medical Faculty at the Sylhet Medical University. So Professor Zaki, please.
Thank you very much for giving me the chance to say something. It's a very nice discussion as well as nice presentation by Professor Rela. We enriched our knowledge through this discussion. I myself have two questions actually. Actually, for our CLD patient or severe liver disease patient, if they are infected with COVID, whether we should use fractionated heparin or unfractionated heparin, which heparin should we choose? And another question is that for liver transplantation, what percent or volume to be transplanted, whether there is fixed ratio or not? And thank you very much for giving me.
What was the second question? Sorry, what was the second question?
What percent or volume of the donor liver to be transplanted, or whether or just to transplant a right lobe or left lobe? What is this? And actually, the volume or percent of the donor to be transplanted.
This is what? This is at the time of the COVID pandemic, or
general? This is general. First one is the COVID. Whether a COVID patient with liver disease, what heparin should we use? Fractionated heparin or unfractionated?
I have to ask our hepatologist. I think we have used fragment for all the patients actually, but not that we have had too many patients. We have only had 2 patients with chronic liver disease who became COVID positive. I can't. I have to ask our hepatologist about that, because this was an early phase. Actually, we lost both of the patients. I'm not even sure if we gave heparin for them. Subsequently, we have not had any patient with chronic liver disease. I don't know the answer. Maybe Mamoon can answer that.
Our one professor of surgery died due to COVID. When he was admitted, he was given fractionated heparin, but the ultimate advice was to give unfractionated heparin, because unfractionated heparin has a short half-life than that of the fractionated heparin. So, what will be the actual treatment, fractionated or unfractionated in severe liver disease patients? So the half-life is some difference.
I don't know. I have to discuss that. I can't give you an opinion about that actually.
And what percentage of the liver to be transplanted in a patient?
See, there is no difference in terms of how you transplant in the COVID era anyway. I think we have a cutoff of a GRWR of 0.7% for transplanting someone. So it depends on whether a right lobe will give the 0.7% or a left lobe will give the 0.7%. I think the minimum requirement should be the 0.7% of their body weight should be the size of the graft. It's not different for the COVID time.
No, I don't want to know about the COVID time. It's the general time.
It's for 7 kilogram person, 70 kilogram person requires 0.7%. So how much is that? It's about 500, minimum of about 500 grams of liver he needs to have.
Thank you very much. Thank you, Shubnil.
Thank you, Zaki Bhai. So next, I will request Dr. Harunur Rashid from the Department of Hepatology, Rajshahi Medical College, for his opinion, please.
Thank you, Professor Dr. Rela, and thank you, Dr. Mahamun Mahatab, and thanks to all my colleagues. It's my great pleasure to join a great learning from Dr. Rela. I have a question. From your data, we can see social distancing, mask using, and eye protection can protect 85 to 86% of the patient. But 15 to 14%, how can we protect?
Yeah, it's a question of reducing the risk. See, that data is not my data actually. I think it's a Nature publication. The point I was trying to make is you can never protect 100% if there is a patient with COVID in front of you. So we are talking about an unknown situation of a patient who's in front of you, who you don't know is COVID positive. That's why in social interaction, in day-to-day interaction, in the hospital, between your colleagues, we advise them to follow all of the precautions rather than to think, oh, I'm working with him, he's negative, I'm negative. Because the implications of people thinking like that and multiple people getting infected is a major problem. So you cannot protect 100%. But you should also remember the length of interaction. They say that if you protect yourself with an eye protection, with an N95 mask and all of that, and if you actually interact with them for less than 15 minutes, the risks are significantly lower. So the time you spend with a person who's also COVID positive is also important in the infectivity. So you can only protect yourself to a certain extent. So if you're actually working within a COVID ward where you know that the patient is actually positive, you're actually wearing a PPE, which is really much, much higher than what we are talking about in order to protect yourself to almost 0%. Even wearing a PPE, it's very difficult to say it can be reduced to 0%.
My another question is, do we think the virus is transmitted by aerosol? The most dangerous place of our specialty is endoscopy room. If a person after sneezing or coughing, how much time it may in the room in aerosol or in air, the virus?
I don't know about endoscopy. I think in today's terms, when you want to do an endoscopy, you have to do a COVID test before you take them for endoscopy. But that doesn't guarantee that there is a false negativity of almost 30%. I would everybody doing endoscopy should have adequate PPE to do the endoscopy. And in today's world, if you think that the patient is suspect, you need to leave at least half an hour in the room for everything to settle down if the patient is coughing. So really, you have to have a half an hour interval in a patient if you really want to do the next patient in order to make sure that everything settles down. See, we do this in an operating theater. When we take a patient for an operation, they intubate them. They actually intubate them, even though we have done 2 tests prior to the operation. They intubate them within a chamber, actually, within a transparent chamber. They put their hand in and then intubate them. The risks are maximum during intubation time. After intubation, except for one person who's in PPE in the room, everyone else will leave the room and allow the virus to settle down. And then only we go in only half an hour later to actually start the operation. So I'm only giving an example of what we do in an operating theater. And I would guess that that would be applicable for you in endoscopies as well.
If the virus is, my question is, if the virus is spread by air, how can I protect, or how can I finish the virus from air?
No, the viral particles, I know that when somebody is sneezing or coughing, it is airborne. But these viral particles are thought to be much heavier, and they do settle down with time. And that's why I said the half-an-hour interval. I know there is some controversy going on currently that it stays in the circulation for a long time, or in a closed room, they stay in there for a long time. But that is really a new thinking coming up, and there is a new worry coming up that it's actually airborne infection. But until now, the WHO stance has been that the virus does settle down. That's why social distancing works. So I don't know if anybody else has got an opinion about that, but the WHO is still sticking to the point that it is the infection is not airborne.
Before I go to the next panelist, just a question from my end. What do you think if we sedate all patients with propofol before introducing the endoscope? Will that be helpful?
Yeah, you're now getting me to answer question for a gastroenterologist.
Yeah, sorry.
I mean, if you stop a patient from gagging, yes, it will be helpful.
That is what I am practicing. So I just wanted your expert.
Yeah, I agree with you. I think there are many common sense ways of doing things to protect yourself.
Yeah.
You know, at the end of the day, if you ask me, see, at least you're lucky that you got antibodies. You know.
So now I go on to Dr. Ashraful Alam. Dr. Ashraf is the associate professor and head of the Department of Hepatology at Shahid Tajuddin Ahmed Medical College. And just to remind you, in the early days, he had received training under you.
I need to look at his face.
They received training in your center in transarterial chemembolization. Two of them went there, and two of us went to ILBS. And when they came back 3 years back, they started transarterial chemembolization. He's one of the pioneers. The next physician who will be speaking is also one of them who was trained in ILBS, and now this in Bangladesh, we are doing that shows how we have also benefited from your collaboration. So, Dr. Ashraf, please.
Thank you. Where is Dr. Ashraf?
Assalamu alaikum, sir. I think you hardly recognize me because when I went to Chennai, that time I was not having beard. But after performing Hajj last year, I having beard.
You're looking professorial now.
Thank you, sir. So good evening. It's been an honor to be present as a panel of experts in this very nice webinar. This is a very tough time we are running in this world nowadays, and every day we are learning so many things and so many new things about COVID infection. So today's webinar that is running in a transplant center during a pandemic, it was not only tells about running a transplant center, but we have learned so many things regarding COVID virus itself and pattern of infection, and so many data you have shown enriched our knowledge very much. Thank you very much, sir. Thank you very much.
Thank you very much. I'm glad you have not asked me a question because I'm now tired of answering questions.
So the last panel expert member will be Dr. Sheikh Mohammad Noor Alam Diu. He is an associate professor of hepatology at the Bangabandhu Sheikh Mujib Medical University. Dr. Diu,
thank you, Professor Mohammad Rela, for this nice presentation.
Thank you.
And it's a very great achievement that an iconic transplant surgeon became a COVID specialist. Thank you very much.
I'm not a specialist. I'm just encouraging people to be involved. because I really seriously believe that it's one of the important responsibility for us to do that. So I'm just motivating people to be involved, and if I have to motivate them to be involved, I have to be involved. I have to learn. I have to be involved.
Thank you.
Thank you.
So thank you, Professor Rela. It was indeed an honor for us having you here. And in fact, you are not a COVID expert. You are a bit more than that. You are not a transplant surgeon. You are a master in transplant surgery. And I can assure you that in COVID management, you have achieved that stature also. So thank you very much, everyone, for attending. This was a COVID webinar, one of the series of webinars that we are arranging. This was hosted by Forum for the Study of the Liver, Dhaka, Bangladesh, jointly with Dr. Rela Institute and Medical Center, Chennai. We had Beacon Pharmaceuticals in Dhaka as the scientific partner, and the media partner was Raj TV. Just for information, Professor Rela will be with us again on the 15th from our Liver Association, asking for the study of the liver diseases Bangladesh. We are hosting another webinar. Then Professor Rela will also be speaking, so we'll be having him back within a week again. So with that, I thank you again once again and conclude this webinar. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Bye-bye.
Thank you.
Goodbye.
We have actually, I mean, we discussed plasma exchange. There have been some publications, but there has been no convincing evidence for TPE actually. The problem with convalescent plasma is because the treatments are so well established now. In the early stage, we give them corticosteroids, we give them anticoagulation, we give them remdesivir. So plasma is actually has taken a backstage unless we wait for there are many studies still going on, unless they say that it's made a dramatic difference to patients. Because for the usage, you see, in the early phase when we were doing this, they said you have to wait for 1 month from a patient to take plasma. They have to have antibody levels. They should have had significant symptomatic disease. And then only you take their plasma and give it. And we didn't have patients who are 4 weeks old to get the plasma. Now
you are watching
now there are many patients who are willing to donate. I mean, I have to say a lot of patients are not even.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.